Good evening, everyone. On behalf of CME Seminars, I'd like to welcome you to tonight's presentation. Our webinar tonight will be Pediatric Infectious Disease Update, presented by Dr. Stephen Eppes. We'll have two approximately 1 hour sessions tonight, followed by two 1 hour sessions next Tuesday. The handout you received may contain a few more or a few less slides, as it was prepared prior to finalization of all of tonight's content. The program was approved for 4 AMA PRA Category 1 credits through joint providership with CME Outfitters LLC and CME Seminars. After the webinar is over next week, you will receive an email with a link to an evaluation. Upon completion of the evaluation, you will automatically receive a PDF of your certificate, and a copy will also be emailed to you. Please note any questions in the message or chat area, and Dr. Eppes will try to address those tonight. If not, we'll save your questions and we'll email them to all of you. Feel free to activate your camera. The audio is muted at the moment. We'll open that up later so that you can actually ask questions if you'd like to. We'd like to thank you for joining us, and be sure to check out our website for our lineup of live events and webinars. So to begin the presentation tonight, please welcome Dr. Stephen Eppes.
This should be fun, and be fun for me, hopefully for everybody else too, and informative as well, I do hope. The first one that we'll do is antibiotic update, and it's basically what it says. And it's partly pediatric, and it's partly, basic science, but hopefully a lot of practical stuff that you can use in your everyday world and practice. And all 4 of these talks, I will use images that have been supplied by CDC, so I want to thank them right up front for their images. So we'll start with a little joke, I guess, an anecdote, the history of antibiotics. So the year 2000, if you feel sick, here, eat this root. The year 1000 AD, that root is heathen, say this prayer. 1850, that prayer is superstition. Here, drink this potion. 1950, that potion is snake oil. Here, take this antibiotic. And now, 2020, that antibiotic is artificial. Here, eat this root. And I'm showing you this because a lot of people demand antibiotics, but there are a lot of people who are skeptical of antibiotics as well. And we're going to go through examples. Now, I always say that the most important parts of antibiotic update are to tell the story of the development of new antibiotics, which is really the story of bacterial genetics, mutation, and resistance. And maybe my most important take-home point tonight is that preserving currently available antibiotics requires us all to be good stewards. So almost half of the talk is going to be on antibiotic stewardship. So another little anecdote, an apple a day keeps the doctor away, at least it once did. But over time, some doctors have become resistant to apples. It may take 2 or 3 to keep them away. Some have become completely resistant. So we must stockpile our finest apples to fend off the very toughest doctors. Galas often work, but we don't know for how long. So this is an interesting chart. It shows on the right the year that certain antibiotics were introduced, FDA approved in the United States. And on the left is when we first learned of resistance in important pathogens to those antibiotics. And as you can see, within just a few years, there has been resistance after an antibiotic has been introduced into the population. The one exception is for penicillin at the top, where we actually knew about resistance in Staph aureus even prior to it being FDA approved. Dr. Alexander Fleming helped us figure that one out. So it's a problem. Microbes are smart. They mutate all the time, and randomly they can become resistant, and that makes life tougher for all of us who are trying to treat sick patients with infectious diseases. This is a slide I've shown many times, and I've had to modify it because things have gotten a little bit better, actually. What you see here is the number of new antibiotics in various time points, and It got pretty serious back in 2008 to 2012. We were really seeing a dwindling pipeline, but it's getting better. And I'll show you some examples. And partly the reason it's getting better is because everybody's working so hard. So my professional society, the Infectious Disease Society of America, has had two campaigns. First, the Bad Bugs, No Bugs campaign, and then the 10 by 20, which means 10 new drugs by 2020, both of which have really emphasized that pharmaceutical companies need to develop new antibiotics. Congress has gotten involved, the FDA, of course, the NIH, and even the Obama White House. So lots of people think that this is a priority. So let me go through some new antibiotics that have been FDA approved in the last few years. I'm not going to spend much time on them because most of them, believe it or not, are not even indicated in pediatrics. But just to show you, give you kind of a flavor of what's happening in the realm of antibiotic development. So meropenem, of course, is a carbapenem, very broad spectrum. You add a beta-lactamase inhibitor to that, Vabarbactam, and you get a very broad spectrum agent, which is useful for resistant gram-negative infections. Delafloxacin is a fluoroquinolone that's useful for skin and soft tissue infection. Zepi, I don't know where they get these names. Somebody in boardrooms must have a lot of fun coming up with these names. This is actually a topical fluoroquinolone that's indicated for impetigo down to 2 months of age, and it's active against MRSA, as are some of the other newer fluoroquinolones. The rifamycin-like drugs have been around for a long time, but just in 2018, one was approved for traveler's diarrhea. We have amaticycline and eravacycline, which are both tetracycline derivatives, which are indicated for adults with skin and soft tissue infection and intra-abdominal infection, respectively, and plasmamycin, which is an aminoglycoside for complicated UTIs. One of our antibiotic stewardship pharmacists called cefiderocol a real game changer. This is a unique cephalosporin-like antibiotic that utilizes the iron transport mechanism to get inside the periplasmic space. It's extremely potent and is currently indicated by the FDA for complicated urinary tract infections, but I think you'll see more uses for that going forward. So you all know imipenem cilastatin, which is Primaxin. You combine that with relebactam, an inhibitor of beta-lactamases, and you get a really broad-spectrum antibiotic useful for UTIs and intra-abdominal infections. And lefamulin is for community-acquired bacterial pneumonia. It's in a class by itself. So there you have it, some new antibiotics over the last few years, most of which, quite honestly, aren't on my hospital formulary, and most of which I have not used. But again, just to give you a flavor of what's out there and the fact that we do have new tools in our toolbox. So what I hope to cover in the next 45 to 50 minutes are how bacteria become resistant. We'll talk about community pathogens and certain hospital pathogens, application of newer antibiotics in the pediatric world, undesirable effects of antibiotic usage, and efforts to control or curtail resistance, and new strategies for antibiotic usage and what amounts to judicious use of antimicrobials, which is so important for all of us to practice. So it happens in one of two ways. You take a susceptible bacterium, and it can either mutate and become resistant to whatever antibiotic is at hand, or you can take that susceptible bacterium and put it in the same milieu with other resistant bacteria. And you know this, there's plasmids and other ways that resistance genes can be transferred from one organism to another. So that can happen, either of which can result in a bacteria becoming resistant. And believe it or not, you know all of these mechanisms of resistance. You've dealt with this in your practice. So decreased permeability is exhibited by gram-negative bacilli, E. coli, Pseudomonas, whatever. So the antibiotic just doesn't get in as well. Drug efflux is used by pneumococcus and Staph aureus. So the drug gets into the bacterial cell, but the bacteria has found out a way to pump it back out so it doesn't get to its target. Drug inactivation means it hasn't gotten to its target because it's inactivated by the bacteria, usually due to a beta-lactamase enzyme or some other enzyme. And then we have altered targets. So gram-positive cocci, like pneumococcus and staph, may have ribosomal methylases that are encoded in their genome so that the ribosome, which is the target of the antibiotic, just doesn't allow binding. So all of these are important. And like I said, whether you've known it or not, dealt with them over the years. But whatever the mechanism is, you take a population of microorganisms in which the resistant strains are the exception, you expose them to the antimicrobial of interest, and what you see is that the antimicrobial will kill the susceptible organisms, but the resistant ones will be allowed to flourish, and they become the dominant strains. That can happen in a person or an animal, and that can happen in a population, depending on antibiotic use. So it's that antimicrobial exposure that really drives it. And let me show you a couple of examples of what can happen in a population and what can happen in your individual patients. So this old chart, you can tell it's old, is from Finland. And in Finland in the 80s and 90s, they were popularly using erythromycin to treat group A strep pharyngitis and other group A strep infections. And what they noticed is that they suddenly saw more erythromycin resistance in group A strep. So being a national health system, they said, let's stop using so much erythromycin. And as a result, within just a few years, the rates of erythromycin resistance went down. So that's what can happen in a population, according to the antibiotic that's being used. The next two slides will show you what can happen in your patient. Really, really important point that I think a lot of people don't always remember. So this study was done by Dr. Brook, and this was back in the days when we used to use prophylactic antibiotics to prevent acute otitis media, which at the time we thought was a good idea, keep kids from getting so many ear infections. But it was probably a rotten idea, because if you give a low dose of an antibiotic over a long period of time, it just teases the microorganisms to become resistant. It invites them to become resistant based on one of the mechanisms that I just showed you. So believe it or not, what Dr. Brook did was he took tympanocentesis samples. So he tapped eardrums of kids who were receiving prophylactic antibiotics, whether it was sulfa like gantricin or amoxicillin, and then grew the organisms out and tested them for resistance. And all of your favorite organisms, pneumococcus, H. flu, and Moraxella catarrhalis, learned how to become resistant. 30, 40% of them during a course of prophylactic antibiotics. You remove the driver, the antibiotic, and continue to assess the middle ear samples, you saw that they returned to a more wild type or susceptible state. And here are 4 studies that were all very similar in the way that they were designed. So what you see here, NSSP stands for non-susceptible Streptococcus pneumoniae, and it looks at patients, and these were both adult and pediatric patients, who were exposed to an antibiotic. They then sampled the nares, cultured out the organisms, and tested for susceptibilities. And what you can see is a striking difference in people who recently received antibiotics versus those who hadn't received antibiotics. So remember, if you've used an antibiotic recently in your patient, let's say you've used amoxicillin, and they come back in with an ear infection within a month, you may be dealing with a completely different pathogen, one that's non-susceptible to the antibiotic. A couple of other important principles just to remind you of. First of all, colonization is not the same as infection. And I'll get to some examples of that a little bit later when we talk about stewardship. But one prominent example that comes to mind is the chronic strep carrier. You've all dealt with this in practice. You know that up to 20% of children are chronic strep carriers during the winter time. In other words, it's in the throat. They come in for another reason, a viral URI or a sprained ankle or whatever. If you happen to do a throat culture or a rapid strep test, you will find that they're positive. That doesn't mean that they require antibiotic treatment. And remember also that we humans are at most 10% human, meaning that our microbiome, the bacterial cells in our nasopharynx and GI tract and skin, outnumber human cells by a factor of 10 to 1. What this means is that if you use an antibiotic for any reason, you're going to expose all those other bacterial cells to the antibiotic with the risk of driving resistance. So some of these slides are from CDC. This is kind of a scary looking one with the skull and crossbones, but it just shows how many antibiotic resistant infections we see in the United States each year. So it's almost 3 million, associated with 36,000 deaths. If you tack onto that the burden of C. diff, which is due in almost all instances to antibiotic use, you have another few 100,000 cases and more deaths. So that's a lot of illness and death associated with antibiotic use, some of which is not always appropriate. So let me ask you, think to yourself, I don't think we have the ability to do audience participation, but think to yourself, what organism worries you the most? Would it be pneumococcus, Staph aureus, VRE, resistant enterococcus, Pseudomonas aeruginosa, or other resistant gram-negatives? And I will show you or tell you that when I give this talk to an audience of ambulatory providers, they usually select pneumococcus and Staph aureus. When it is a group of hospital providers, they're usually worried about resistant gram-negatives. And I'll show you a couple of good examples of that in a couple of minutes. So I'm going to talk about, as I said, both inpatient and outpatient organisms. The CDC has tiered their threat level for certain organisms. So they have urgent, which is the highest threat level. So of all of the organisms on this chart, the one I'm going to be talking about is carbapenem-resistant Enterobacteriaceae. They have the next tier, which is serious threats. So I'll touch on ESBL-producing gram-negative rods and Pseudomonas, and also organisms that you see in the community, Staph aureus and Streptococcus pneumoniae. And then concerning threats is the lower tier, which I'm not going to have time to really go into, but these are important and we have to keep an eye on them as well. So here's a gram stain of pneumococcus, a serious pathogen that you see in practice on a pretty regular basis. We didn't have much of a problem in the United States until the 90s. And by the year 2000, nearly 30% of pneumococcal organisms were either fully resistant or intermediately resistant to penicillin. Here, the resistance is mediated by alterations in the penicillin binding proteins, which make up the cell wall of the organisms. So you probably remember that from medical school. The good news is that this kind of resistance can be overcome by higher doses of penicillin or penicillin-like drugs, which is why, the familiar example, we've gone from 40 milligrams per kilogram per day of amoxicillin to 80 to 100 milligrams per kilogram per day to overcome this kind of resistance. Here are recent susceptibility data for Streptococcus pneumoniae, and you'll see that penicillin has 2 breakpoints for susceptibility. The top one, which makes it look worse, is for meningitis, CNS infections, because you have to raise the bar if you're going to be treating a serious CNS infection where antibiotics don't always penetrate the CNS very well. But for most outpatient infections, we use a breakpoint of 2 micrograms per ml to define susceptibility. So you can see that in the community, 84% or so are susceptible, and about the same for amoxicillin. Ceftriaxone, a little bit better. Erythromycin, which used to be perfectly good against pneumococcus, is down to around 60%, and the same with all of the other macrolides. Likewise, Bactrim, or trimethoprim sulfa, which used to be very good against pneumococcus, is down around 66%. Levofloxacin is still good, 99%, but don't rush to write a prescription for levofloxacin for pneumococcal infections, because we really should be very, very careful with how we use the fluoroquinolone antibiotics and only use them according to the FDA when no other alternative antibiotic is suitable. So most of your pneumococcal infections will be treated without knowledge of a positive culture and without susceptibility data. And these are the infections that you see in an ambulatory setting or even in a hospital setting. So sinusitis, which is often due to pneumococcus, the recommendation is to use either amoxicillin or amoxiclav. Otitis media, same. For community-acquired pneumonia, you have several options as seen there. For adults, amoxicillin or doxy or macrolides, if your local pneumococcal resistance is not high, are alternatives. And for children, amoxicillin is still your usual go-to drug for community-acquired pneumonias. Again, most of the time you're not going to have a positive culture to go off of, but we know this based on data, microbiologic data that is acquired in other ways. So here is a nice photomicrograph of a gram-negative rod that is, you wouldn't know it by morphology, but it happens to be E. coli. So here's my opportunity to talk to you about enzyme-producing gram-negative rods. And I apologize, this is way oversimplified, but I just want to drive home a few important points. So first of all, the ESBLs. We've known about these for a couple of decades. These are extended spectrum beta-lactamases. Beta-lactamases break down beta-lactam antibiotics. These are most common in E. coli and Klebsiella, but can be seen in other gram-negatives as well. We learned about them first in hospitals, but now they're seen more and more in community settings. And so don't be surprised if you see one of these in a cute little girl who comes in with a urinary tract infection, because they're common in that setting. They can also infect wounds. They can lead to bacteremia, especially in people with coexisting medical conditions. But these enzymes confer resistance to all penicillins and all first through third generation cephalosporins. Then there are the KPC enzymes, and KPC stands for Klebsiella pneumoniae carbapenemase. So these lead to resistance to our carbapenem antibiotics, which are already really broad spectrum. Now, there are other mechanisms that you can get CRE, but this is one of the most important ones, and one that I just wanted to make sure you knew about. And then finally, we've known about NDM1 enzymes for over a decade. That stands for New Delhi metallobeta-lactamase. So these are really highly resistant organisms that can hardly be treated with antibiotics. It's called New Delhi because these enzymes originated in E. coli and Klebsiella in India, but they've traveled to all parts of the world. Here is an inpatient at my hospital, Christiana Care, and tell me if you don't think that's scary. This is a wound culture, and what you can see here is lots of R's and one I and no S's. So multiply resistant, highly difficult to treat infection. We don't like to see these. So what are your tools in the toolbox to take care of the multi-drug resistant gram-negatives? Well, cefepime, which is a broad-spectrum fourth-generation cephalosporin, is good. It's dose-dependent, meaning that you may have to use a higher dose. Imipenem and meropenem, which are carbapenems, are good against ESBLs, and aminoglycosides may work as well. For your CRE organisms, harder to treat. That's why we've got some of these new antibiotics that I told you about at the beginning that have recently been approved. So you can use ceftazidime with avibactam or meropenem-vaborbactam to treat CREs. There's the combination of ceftolozane, which is a cephalosporin, and tazobactam for multi-drug resistant Pseudomonas. Tigecycline, which is a tetracycline derivative, which may be used, although has some drawbacks, and colistin, which is an old antibiotic. We've had to take off the shelf to treat some of these highly resistant infections, colistin being very toxic and difficult to administer. So again, you're not going to be using these drugs with any great regularity, but I wanted to show you what's out there. Here's a photomicrograph of Staph aureus. Of course, it's gram-positive cocci in grape-like clusters. What you see in the clinic or office setting are mostly skin and soft tissue infections. But just to remind you that Staph aureus, whether resistant or not, cause invasive infections in children as well, such as this, osteomyelitis, and this, necrotizing pneumonitis. And you can, I hope, make out the pneumatocele in that right upper lobe pneumonia. So you may not remember this, but when Alexander Fleming discovered penicillin in the late 1920s, he discovered it in the setting of Staph aureus, and penicillin was highly active against Staph aureus. Well, as you know, it didn't take long for penicillin resistance to develop. Some of that happened on the battlefields of World War II. So scientists had to go back to the laboratory, and they came up with the semi-synthetic penicillins like methicillin and nafcillin and oxacillin that were used for treatment of penicillin resistance. And of course, that led to methicillin resistance. We call that MRSA. That happened in the 80s. Then we had to take this old antibiotic off the shelf, vancomycin, and so it was widely used in the 90s, leading to the completely unpredicted and unpredictable consequence of VRE. And then through the 90s, as we used more vancomycin, we began to see intermediately resistant Staph aureus called VISA. And then finally, vancomycin resistant Staph aureus. And back in 2002, when this was first observed, this was very scary because here you have a high-grade pathogen basically resistant to almost everything that would be used to treat it. Now we have more options, and MRSA has changed. You know, what we used to see was the old hospital-acquired MRSA, and now we see what used to be called the community-acquired MRSA, which is a different strain, a different beast that is bad. It causes all those infections that we just talked about, but the good news is it has more antibiotic options. So here are some choices for MRSA infections. On the left would be your oral antibiotics, and on the right, the parenteral choices. And everything that's oral is also available in parenteral forms. I'm going to focus mostly on the oral antibiotics because I think that's what most of you will be more likely to be using in practice. So think about this. What is your usual antibiotic choice for MRSA skin and soft tissue infection? And I've given you some of what I think are the most popular choices, but there may be others as well. When I do this for a live audience, I usually get a nice array of responses. But let me go through what I think are the pros and cons of each of these choices. So clindamycin is a favorite for a lot of people, and it is active against most MRSA and MSSA, but not all. It depends on where you live, but anywhere from 10 to 30% of your Staph aureus may be resistant to clindamycin. So it's not perfect. It's not a panacea, and you have to know that. And you may want to check your local antibiograms to find out what your rates are in your community. It's also active against group A strep, and that's a plus because sometimes you're treating let's say a cellulitis where you're not sure if it's staph or strep. So clindamycin may be a good choice in that setting. And it's also inexpensive. The cons are what I just told you, that you may have resistance to staph. The oral suspension, as you probably know, it does not taste very good and is not a great choice for some young children who may not be able to tolerate it. It can cause diarrhea, and more often in adults than in children, it can cause C. diff. Trimethoprim sulfamethoxazole is another popular choice. It's really active against staph. At my old hospital, it was 99%. Where I am now, it's around 93, 94%. So you have to pay attention to your local antibiograms, but it's very good against Staph aureus. It's also inexpensive and generally well tolerated. The cons would include the fact that it's not active against group A strep. So if you're treating a cellulitis where you may not know, is it group A strep or staph, Bactrim may not be such a good choice. And compared with beta-lactams, it can cause pretty significant allergic reactions. And then doxycycline is a favorite for many of our adult providers. And it is active against staph. It's inexpensive and generally well tolerated, but it's not a good choice for group A strep. It can lead to severe reactions. I've had many patients who've gotten esophageal burns or really severe photosensitivity reactions as a result of doxycycline, and it's not a good option for children or pregnancy. So this is a parenteral agent, just to call your attention to, ceftaroline. It was approved for adults a decade ago. It was approved for children 4 years ago. This is a so-called fifth-generation cephalosporin. It has excellent safety profile, and it's got really broad spectrum activity. You can think of it as ceftriaxone, which you're all familiar with MRSA coverage. So it's a good drug for MRSA. And I think it's probably underutilized. I think if you're treating infection that's polymicrobial, or you're just not sure, but that MRSA could be part of the problem, it may be a pretty good choice for you. Here are two glycopeptide drugs that were approved in 2014 for adults. Just to show you what's out there, these are pretty unique, dalbavancin and oritavancin, both parenteral only, both with this incredibly long half-life, such that you can give one IV infusion and treat a pretty serious infection, or you can give weekly infusions times 2 or times 3 to treat really serious infections due to resistant gram-positive organisms like MRSA, Enterococcus, or pneumococcus. So I'm going to shift gear a little bit here and talk about, as I said, about half of this talk is going to be about how to use antibiotics wisely. So question for you to ponder. Which of the following is not true concerning the use of antibiotics? More antibiotics are used in the hospital than in the community. Recent changes by the FDA have made it harder for food animals to be given antibiotics. Older physicians prescribe more antibiotics than more recently trained physicians. Each year, 70,000 children present to U.S. emergency departments due to antibiotic adverse effects, or one course of oral antibiotic can disrupt the gut microbiome for a year. So there's only one correct answer here, and it happens to be A. B, C, D, and E are all correct, and I think rather interesting as well. It's a balancing act, really. These are the pros and cons of using antibiotics. Obviously, our goal is to cure bacterial infections, but we have to balance that against some of the unintended effects, such as adverse drug reactions. 70,000 kids a year go to emergency rooms because of this. C. diff infection, more common in adults than kids, but a real problem. Risk of resistance, which is what I'm going to focus on, and of course the costs that are involved. If you went to the CDC website right after tonight's talks, you'll find this there. CDC over the last couple of decades has had a number of initiatives to combat antibiotic resistance, and there are a lot of important things the CDC's been doing. They've been kind of tied up with another thing, recently, but this is still a really, really important problem for the CDC. But what do they do that you and I can all do, which is this? We can use antibiotics appropriately, reduce unnecessary use, and ensure improved access to appropriate antibiotics. This is a concept you may not have heard before, but it's a really important one. So as I'm talking about antibiotic stewardship to you, or antimicrobial stewardship, one of the most important first steps is testing stewardship. The idea here is that you don't order a test or interpret a test result in a way that will lead to unnecessary antibiotic treatment. So if you're dealing with an adult patient that has a chest x-ray with a little fluid and the radiologist says, uncertain, is this congestive heart failure or pneumonia, clinical correlation required, that's one instance where testing stewardship can be used. How about urine cultures, which may detect asymptomatic bacteriuria, which we shouldn't treat in the vast majority of patients? Or that familiar example I gave you of throat cultures in pediatric patients when URI symptoms are present. If there's a snotty nose and a cough and hoarseness, that's not likely to be strep. But if you culture that throat, you may uncover a group A strep carrier, and then you're going to be tempted to treat that patient. So antibiotic use in hospital has been a focus of antimicrobial stewardship for decades. We know that over half of patients in hospitals receive antibiotics, and much of this is unnecessary or inappropriate, vancomycin being the classic example. So hospitals and health systems have developed antimicrobial stewardship programs with goals of improving patient outcomes, curbing resistance, and reducing costs. And a lot of people think that we have these programs mostly because of cost, but that's really not true. It's for all three of these. So I mentioned CDC has been interested in this for a long time. This was one of their older initiatives, but the points here are just as true as they were 15 or 20 years ago. So to prevent antimicrobial resistance in hospitalized patients, it could be adult or pediatrics, we have four main strategies. Prevent infection. Well, that could be immunization. Prevent transmission, like hand hygiene. Diagnose and treat infection effectively, which is what I'll focus on, using antimicrobials wisely, being a good provider. I asked Nicole, who is the head of our antimicrobial stewardship program, Nicole, give me some talking points for audiences. You know, when I'm talking about stewardship, what do you want me to emphasize? And so I'll just read for you what she told me. She emailed me this back. Antimicrobial stewardship is ensuring the right antibiotic at the right dose for the right duration is being used to treat an infection in an effort to improve patient outcomes and minimize risk of unintended consequences, like C. diff resistance, toxicity, and cost. Stewardship is not something we do to you, but rather with you. So don't resent it if the stewardship pharmacist gives you a call and says, you know, would you like to consider something different? The goal is to empower both providers and patients to make smart antibiotic choices. She talked about the 5 Ds of stewardship, which is the right drug, the right dose, de-escalating, meaning if you started with broad spectrum agents, then narrow or use less costly agents, use appropriate duration, and discernment, which maybe should be the first D, which is should that patient really be on an antibiotic to start with. And then Nicole finally said, the antimicrobial pipeline is slim and resistance is on the rise. We are limited with our treatment options, often forced to use less desirable, more toxic and costly medications. And I hate it when we're forced to use medications like colistin. So here are some of the strategies that have been used by hospital stewardship programs, basically going from least effective to most effective. So passive prescriber education is what we're doing here tonight. And even though I just said least effective, I hope you're going to take home some important points about stewardship and be a smart antibiotic user. But all those other things have been used and still are used by various healthcare organizations to help everybody improve antibiotic use. The very bottom is computerized decision support or online ordering. So that kind of almost takes the thinking out of it. That's the bad news. The good news is it really does result in improved antibiotic use. So you put in that the patient has cellulitis and that the creatinine is this, and other patient important factors, and it will give you recommendations for what to order. So here's CDC again, working to reduce unnecessary antibiotic use. And here they're starting to approach what's going on in the community because more antibiotics are used in the ambulatory setting by far than in the hospital setting. So it's appropriate that finally we're starting to look at community stewardship. So I'll show you a couple of publications. So this one from JAMA from 2016, they looked at the prevalence of inappropriate antibiotic prescriptions during 2010, 2011. And found out that almost 13% of visits resulted in an antibiotic prescription, and that per 1,000 population, that was over 500 antibiotics written annually. So that's a lot. And in their study, they thought that about 30% was inappropriate, with the biggest opportunities being antibiotics prescribed for acute respiratory illnesses like colds or acute bronchitis, which are almost always viral. And in this study, the most overprescribed antibiotic was azithromycin. Here was another 2016 study that was kind of interesting in the way they did it. So, we have national guidelines for what should be recommended for first-line therapy for various conditions. So for sinusitis, amoxicillin or amoxiclav, otitis media, same choices. Strep throat, it would be amoxicillin or penicillin. And then they looked across a large number of healthcare settings at how often first-line therapies were used. And they found huge inconsistencies, from a low of 37% of adults with sinusitis or strep being treated with first-line therapy, to a high of children with otitis media, 67% were given first-line therapy. So a lot of room for improvement there. And in this study also, the most common non-first-line therapies were either azithromycin or second and third generation cephalosporins for non-allergic patients. So who is prescribing antibiotics in the United States? It's an interesting array. Only 43% are primary care physicians. A growing percentage are mid-level providers like PAs and NPs. How about 9%, almost 10% of dentists account for almost 10% of antibiotic prescriptions. So all of us, this message is for all of us to try to do as good as we can. So who's the new kid on the block? Not on that pie diagram is direct-to-consumer telemedicine, which has, as all of you know, been a really important way to see patients during the COVID-19 pandemic. This interesting article published before the pandemic showed that 52% of telemedicine encounters for acute respiratory tract infections resulted in an antibiotic prescription in pediatric patients, compared to 32% of primary care encounters. So I think we all have to be careful with how we use telemedicine and the people providing telemedicine encounters. Now, you're at a disadvantage. I understand. You can't auscultate, you can't palpate. You may not be able to visually inspect the eardrum, etc., but I think we all have to be careful. You can go on the CDC website and look and find out how your local community is doing. This was actually slightly old data, but I show it because back a few years ago, Delaware, which is where I practice, we were a little too red. And I'm not saying that in a political sense, but we were using too many antibiotics in the ambulatory setting. So we set about to fix that, and it took every healthcare system in the state to work together to do that and to get the message out and to talk to MAUs and to talk to individual practices about how they can improve on their antibiotic use. So let me show you an old study and then some newer data. So this is CDC back in the 1990s. They convened these focus groups saying, why are people using antibiotics so much? And it turned out that parents and patients, they basically wanted a clear explanation. And of course, green nasal discharge, that has to be bacterial infection, and they need to get back to work. And if it's the parents that brought the child in, they need to take that child back to daycare. That was on the one side driving prescription of antibiotics. The other side was physicians. Like the patient expects an antibiotic. Maybe I don't have time to give that clear explanation. Diagnostic uncertainty. Is it a cold or is it sinusitis? Time pressure. All these are very real. And it led to a big spike in antibiotics being used 25 years ago, 30 years ago. So here is what modern surveys have shown to be the drivers of, or I should say, challenges to outpatient stewardship in more recent years. Again, it's time constraints, and it may be parental pressure. We now have patient satisfaction metrics. Some of you probably are having to deal with that. So it cuts both ways, unfortunately. Diagnostic uncertainty again, and in the outpatient setting, you're often faced with not having definitive microbiologic data, not having a dedicated pharmacist like we may have on the inpatient setting. Maybe it's fear of litigation. If I don't use this and the patient gets worse, what's going to happen? And then there are real concerns about physician knowledge, about organisms and resistance, which we're talking about today. So what can you do in your practice if you're in an ambulatory setting? Well, you can display a public commitment for stewardship. This is probably the most powerful thing you can do. We did this in our medical aid units, and it made a big, big difference. And so you can get these charts to hang on your office wall or in your clinic, just saying, to your patients as they're waiting to be seen, this is how we feel about prescribing antibiotics. Very, very powerful. Communication skills training. Everybody in the office, everybody in the clinic should know that it's our goal to use antibiotics appropriately and not slip up and say, oh, he'll give you some antibiotics for that. Maybe requiring written justification for non-recommended antibiotic prescribing should be used. And if you're in a large healthcare setting, you may have an electronic health record, which requires you to do that. That's a very powerful tool as well. Tracking and reporting antibiotic use and providing audit and feedback to prescribers is an important strategy. Education, again, that's what we're doing today, and patient education as well. And then finally, we're just paying attention to this in the last couple of years in the pediatric world, which is delabeling inappropriate antibiotic allergies. 10% or more of children are labeled with antibiotic allergies when there's no real good basis for it in many cases. They got a rash, nondescript rash while receiving amoxicillin, and they're labeled penicillin allergic, and then they're getting azithromycin or some other less appropriate antibiotic for whatever condition they develop. In terms of patient education, it's important to set expectations. So, for example, let people know that all URIs and most pharyngitis and most acute bronchitis are viral. And maybe you can do yourself a favor by using the term chest cold rather than acute bronchitis, because acute bronchitis, hey doc, that sounds bad. We need an antibiotic for that. But a chest cold sounds like kind of a bad cold. And let people know that they can expect to be sick for about a week, and that symptomatic relief may be all that's required to make them feel better. If you do use antibiotics, be judicious. Select as narrow spectrum agent as possible to cover the most likely pathogens. Select the appropriate dose and treat for the shortest duration required. So years ago, we used to use kind of an average dose of amoxicillin or whatever antibiotic and tell them, be sure and take it all 10 days. But that was probably not the right way to do it, unless it was group A strep, which we know you have to treat for 10 days. Really, you should attack the infection with a high dose and treat it for the shortest duration required. And then remember WASP and SNAP, the role of observation and delayed prescribing. So WASP stands for wait and see prescription, and SNAP stands for safety net antibiotic prescription. Same thing. And you can get this from the CDC. They want you to do this. So you can get these tear-off pads. Wait, don't fill your prescription just yet. Let's try these other things and wait and see how you do. So let's say you're not sure if it's a bacterial sinus infection or if it's just a prolonged cold, or if it's an older child who has otitis media that you think may get better with no antibiotics. Use this WASP approach or SNAP approach if you prefer. So I'll end with a little good news, which is that we are doing better as a result of everybody out there, taking this seriously. So newer data compared with, let's say, 2010, which I showed you, shows that we're down in total prescriptions and even more in pediatric prescriptions. And the ratio of broad spectrum to narrow spectrum antibiotics is also down, mostly due to reductions in macrolide use and quinolone use. So this is all good news. And then word to the wise. Word to the wise. I told you at the beginning that we're all loaded with bacteria, right? We have the skin microbiome, we have the respiratory microbiome, the vaginal microbiome, the GI microbiome. And every time we give an antibiotic, it affects those and the microbiomes. And I worry mostly about the gut because it has such important functions. All of us need our bacteria in our gut to digest things. They help with other metabolic functions. The friendly bacteria perform a barrier function. They compete with pathogenic organisms like C. diff. And they are important in our host immune response, like, for example, to immunizations. And if you mess with the gut microbiome by giving antibiotics, it disrupts some of these functions and leads to really potentially serious problems, especially with repeated courses of antibiotics. So some of the things that have been observed with disrupted gut microbiome include susceptibility to certain infections, C. diff being the classic example. Young premature infants, it's been shown that antibiotic use predisposes them to necrotizing enterocolitis. Inflammatory bowel disease in pediatric and adult patients has been linked to previous antibiotic use at a young age. Likewise, atopic diseases, and we're scratching the surface of this, but just this week there was a great study that was published that showed that asthma is more common in kids who've had a disrupted microbiome. Other inflammatory diseases, there's a publication showing systemic JIA or JRA is more common if you received antibiotics at a young age. And then there are metabolic consequences like obesity and type 2 diabetes, and even, believe it or not, kidney stones. So that's some of the scary stuff that's out there. Again, just learning about the microbiome and how important it is for human health. So I will close with a few quotes and then open it to questions. So first quote is from Nobel laureate Joshua Lederberg, who is a big pneumococcal guy. He said, pitted against microbial genes, we have mainly our wits. So we have to be smart. Sir William Osler, who was really an ID guy, said that the desire to take medicine is perhaps the greatest feature which distinguishes man from animals. There's truth in that, and that was 100 years ago plus. In theory, there is no difference between theory and practice, but in practice there is. So remember the theory. Remember what we're talking about tonight. And then Groucho said, those are my principles. If you don't like them, I have others, meaning stick to your principles. So at this point, I am going to ask for questions, and we'll find out if I'm smart enough to use the snap function. Which unfortunately I'm having trouble seeing. I don't know, Rick, if there are any questions being chatted, maybe you can moderate.
No, there are none in there right now. During the 5-minute break, if you do have a question, why don't you type it into the chat, and Dr. Eppes will answer that when he comes back. And at this point, I think we're going to take a 5-minute break while Dr. Eppes switches presentations. And please join us back in here in 5 minutes. Take a quick break. Thank you. Welcome back, everyone. We're going to get started here with our second talk for the evening. And Dr. Eppes, I will turn it over to you.
Thanks again, Rick. I have to tell you, when Rick asked me to do this, I said, wow, this is going to be perfect timing to talk about the flu, because flu season should just be getting going. And, you know, the audience can hopefully get some important stuff out of this. But this is going to be an interesting flu season, as I will show you in several different ways. Still, some of what I'm going to tell you, I think, will be useful, not only in this season, but in seasons going forward. So I want this to be very practical. I want to talk about the virology of flu, and I want to talk about the epidemiology, but that's basically to set the stage for talking about how to treat it and how to prevent it. So in terms of virology, I'm showing you a cartoon of the virus. There are some important structures that I will refer to, particularly the hemagglutinin and the neuraminidase, which are proteins on the surface. And there's the ion channel that allows entrance and egress from cells, and the RNP, the ribonuclear protein, which is the genome of the organism. So we have influenza A, influenza B, and influenza C. C we don't worry about because it's not an important human pathogen. Influenza A it can be subject to both antigenic shift and antigenic drift, which I will define. And it's the cause of pandemics like we had in 2009. Influenza B can have antigenic drift, and there are two lineages. I hope you know this, but there are Victoria and Yamagata, and because there are two lineages, most of our flu vaccines have gone to a quadrivalent formulation to cover both of the B strains. And these are kind of sometimes underappreciated. They can cause severe disease. Sometimes they cause higher mortality than influenza A in children. So forgive me if I spend too much time on this, but I think it's interesting. So the hemagglutinins and neuraminidase, there are 18 H types, all infect birds, and some infect other mammals, pigs importantly, and some infect humans. They all can infect birds. So when you say bird flu, that's a bit of a misnomer because birds can play host to all 18 H types. And there are 11 N types, cleverly numbered 1 to 11. So remember that ribonuclear protein, the genes of the flu virus are segments of RNA. And so if you get two different flu viruses into the same host animal, into the same cell, and they both get into the cell, uncoat, and release their segmented RNA genome into the cytoplasm, then as those viruses then reassemble and are released into the extracellular environment, they may undergo what's called reassortment, meaning that they swap genes. So the red virus there has picked up a yellow gene and the yellow virus has picked up a red gene. That is reassortment, and that is antigenic shift. That is a major genetic change, which results in a major antigenic change in the virus. That's what leads to pandemics. The result here is that many in the human population don't have existing antibody, and so you get widespread disease. This typically happens every 10 to 14 years. We were overdue for it in 2009. Who knows when it'll happen again? Then the pandemic strain circulates as the yearly epidemic strain. So in 1918, 1919, the Spanish flu, that was an H1N1, and then it circulated as the endemic strain until 1957. The 2009 H1N1 has circulated every year since then, not in a pandemic fashion. Antigenic drift is a more minor genetic change that results in antigenic changes. This happens all the time and can involve both the hemagglutinin and neuraminidase proteins. So if you have pre-existing antibody, either from previous infection or from a vaccine, it may not protect very well against the drifted strain. And then you get this phenomenon of immunologic selection so that the drifted strain becomes more dominant in a population and becomes the circulating type of that H or N type. So let me go through a little history for a few minutes. So there are novel viruses that appear because of the epidemiology of influenza viruses. So they're common in other animals, they're common in birds, they're common in aquatic mammals, they're common in pigs. You put pigs and birds next to each other, such as we often see in China, and you get novel strains that then circulate and can be very scary. So both the H5N1 and the H7N9 are highly pathogenic avian influenza strains that originated in China. These were really scary, still are scary. H5N1 was the one that scientists were most concerned about as causing the next pandemic. I'm talking about 15 years ago. That turns out not to be the case for right now, but it could be in the future. And I'll come back to that when we talk about vaccines. But these are very highly pathogenic in birds. They can cause human infection, and that's often severe. Fatality rates of 20, 30, 40%. But fortunately, person-to-person transmission is not frequent. So bad viruses that so far have not caused widespread disease because they're not officially transmitted one person to another. So the symptoms of avian flu, they're very nonspecific, as you can see. It's all the stuff that you're used to. But if you ever see this one in a patient, that is almost always going to be bird flu. So recent history. So back in 1998, and scientists weren't even paying attention to this. We learned about it afterwards. Everybody's focused on H5, quite honestly. But in 1998, we know there were some reassortments of various flu strains in North America. Some of these involved the H1N1 from the Spanish flu, okay, which was from 1918 to 19, very similar, that lived in pigs all this time. One of these reassorted with the Eurasian swine flu to create a quadruple reassortant, which was the 2009 H1N1 that, if you were around back then, you remember because it was a bad flu year. So this virus had some remnants of the 1918 virus, and what that resulted in is the fact that if you were living between 1918 and 1957 and had exposure to that H1N1 virus that was circulating, you probably had immunity to the 2009 H1N1. So 2009 was our last pandemic year for flu. We got another pandemic going on right now. And it was very widespread. In the United States, it was 100 million cases and 400,000 hospitalizations, but only 16,000 deaths. I say only because that's 16,000 people that died, but that's much fewer than die in a typical flu year. The reason for that is because who usually dies from the flu? People older than 65. Most people had immunity to this virus. Most older adults had immunity to this virus based on what I just told you. More recent history, H3N2 variant. So these were first described in 2011. These were swine strains of flu, and they've been seen every year since then. So these are swine viruses that are often seen in pigs in county fairs and in state fairs. And when humans got them, and it was often children, it was associated with pig contact at fairs. The good news is no fatalities. So the advice from CDC is that high-risk people should avoid contact with pigs to avoid this H3N2 variant. We're coming up on very modern history. This was the 2019-2020 flu season. This was an odd one. I've never seen one like it. So it started out, you see the green at the bottom, those are B strains. So we had both Victoria and Yamagata circulating. So it started off as a B. Usually the flu season ends with B. This started off with B, and then it morphed into an H1N1 predominant year. Really strange, and moderate in severity. Not nearly as bad as some of our other more recent flu seasons. So if you know that when it was our summer, July and August, it was winter in the southern hemisphere, okay? So we in the northern hemisphere pay very close attention to what's going on in the southern hemisphere to try to know what to expect in terms of our flu viruses and our flu activity. And in fact, we pay attention to that sometimes to help decide what strains to include in the flu vaccines. So 2020 Southern Hemisphere flu season was very mild. Low levels were reported across all countries in the Southern Hemisphere that report flu. Some countries reported none or sporadic. Now, this probably was a result of masking and socially distancing, the same thing that we're doing here, hopefully, in the United States and the rest of the Northern Hemisphere. But World Health Organization cautioned this could be due to other things too, like healthcare seeking behaviors, like people don't want to go out if they get a respiratory illness because they don't want to be in a waiting room with somebody who's got COVID. Could be due to staffing routines in sentinel sites that do the reporting, meaning that they don't have enough of their staff there because they've got COVID. It could be due to testing priorities. Some countries may focus on COVID and not flu. But whatever the reason, and I hope it's masking and socially distancing, it was a very mild flu season in the Southern Hemisphere. And so far, this is the season in the United States. It's been a very mild year. I don't remember, and I've been a flu watcher since I was a fellow in the 1980s. I don't remember getting to December 1st and having this little flu. There's just not much around. If you look at a map, there's nobody's got much flu going on right now. What is there is kind of a smattering, a little of this, a little of that, A, H1N1, B, a little bit of H3N2. So we will see. We will see. So more on epidemiology. How is this virus spread? Droplets. There you see nice droplets spread. And spread person to person. There's no animal intermediary. We know that surfaces can become contaminated, so fomites can play a role, but mostly it's by respiratory droplets. Now, I don't want to underplay fomites and surfaces. We should all be very careful not to sneeze into our hand and touch a doorknob and things like that. But I think mostly we have to pay attention to droplet transmission, kind of like COVID, right? People are infectious during 24 hours before the onset of symptoms, kind of like COVID. Viral shedding is maximal during the first 3 days of illness, kind of like COVID. Viral shedding may last a week or so, and the incubation period is 1 to 3 days. It's shorter in a pandemic year when nobody has, or not very many people have immunity to the virus. We have an incubation period that approaches 1 day. In epidemic years, non-pandemic years, it's more like 3 days from exposure to clinical illness. So here is the iceberg of influenza burden in the United States. So deaths, remember, up to 49,000 in a seasonal endemic year. Lots of hospitalizations, lots of cases, and lots of costs associated with that. Children play a really important role or part in the epidemiology of influenza. If you want to know when influenza has come to your community, look for high school absenteeism. If schools are reporting 15%, 20% absenteeism, that's usually due to flu. And then it goes from school-age kids, they take it home, give it to their parents, their siblings, they go out into the workplace, and within a couple of weeks, everybody's getting the flu. And that results in community outbreaks that can last a couple of months, can sometimes last 4 or 5 months. The peak is usually between January and February, but it can be in different years are different. I'll show you a graph. Peak times can start in November, and in a couple of recent years, we've had it go out into May. We often see different viruses. So you'll see A in the beginning or B in the end, or like this other weird year we just had, you see B in the beginning and A at the end. You can sometimes see a camelback, a double hump of one virus circulating and starting to go away, and then you see the other virus circulating. No two flu years are alike. So this gives you the recent 9 flu years, 8 flu years, and just shows you how different they can be. The red triangles at the bottom are the current season, so it's really not gotten off to much of a start yet. Highest hospitalization rates are seen in young children and in older adults. And I think sometimes people don't remember that children under 2 years, and especially under 6 months, can get pretty sick. And they usually don't die, but they can often be hospitalized. About half of pediatric hospitalizations and half of pediatric deaths are in kids who have no risk factors. They're otherwise normal kids, which is why we have to immunize everyone, as I'll get to. Fatal outcomes are more common in the elderly and in patients with pre-existing medical conditions. And among the pre-existing conditions, we learned loud and clear in 2009 that pregnancy and obesity were both important risk factors for severe disease. So here are the clinical manifestations. The onset is usually sudden. Most people can tell you the day and even the hour that they got sick. And one of the reasons for that is that influenza viruses are powerful inducers of interferon. When your cells of your body start making interferon, you feel crummy, you feel achy, you feel chilly. And so that's why people often experience an abrupt onset of symptoms. So you see fever, of course, chills, headache, myalgias. Children can get GI symptoms, although less in adults. It's a respiratory virus, so it always causes respiratory involvement. You can't call it flu if they don't have respiratory symptoms. And it can be from the tip of the nose to the distalmost alveolus. So you can get nasal congestion, rhinitis, sore throat, conjunctivitis. Cough is almost always present, often associated with that deep substernal chest pain on coughing. Children can get croup, and anybody can get dyspnea. All right. I hope in fact, I know you're sick and tired of this pandemic as I am. I'm talking about COVID-19, but we're looking at a bad winter, guys. And so this chart contrasts some of the viruses that you may be seeing this winter and some of the clinical findings. You're not always going to be able to tell. It's going to be, and I don't want to be a downer, I really don't, but this is going to be a bad winter. Now, common cold symptoms, they're a little different. I think you could probably distinguish that. That's rhinoviruses or maybe the seasonal coronaviruses, not SARS-CoV-2. But between COVID-19 and influenza, there aren't really a whole lot of good distinguishing factors. Onset may be in that COVID is a little more gradual. Rhinitis may be in that COVID, it doesn't seem to be as big a problem. And loss of taste or smell is fairly unique to COVID. But barring those findings, it's going to be tough to differentiate. Well, back to flu. Uncomplicated flu, the typical duration of acute symptoms like fever is 3 days, but it can be 8. You get gradual resolution of the respiratory symptoms, but the dyspnea can take, weeks, literally weeks to get better. So tell people they may not be 100% at the gym, even though they're afebrile. We worry about the complications because that's what kills people who have the flu. So pneumonia in influenza comes in 2 varieties. So primary influenza viral pneumonia is often bad. It often happens early in the course of the flu. So the virus gets down into the lung parenchyma and causes a bad viral pneumonia. More commonly, we see secondary bacterial pneumonia. So the virus gets in, it roughs up your cilia, your respiratory epithelium. So that allows bacterial organisms to get a foothold. So we see mostly pneumococcus, but also Staph aureus causing secondary bacterial pneumonia, and that does include MRSA. Another complication is that people who have chronic lung disease can get a lot worse. Myositis is mostly a pediatric complication. So if you see a kid coming in flu season saying, my calves hurt, he's got a fever and his calves hurt. I don't know why, it's almost always the calves. That's usually going to be influenza B. Guillain-Barré syndrome, people worry about Guillain-Barré resulting from influenza virus vaccination. It's more common, much more common, as a result of natural influenza virus infection. There have only been a few years where the flu vaccine has been associated with Guillain-Barré syndrome, but anybody can get Guillain-Barré any year when they get the flu. And then Reye syndrome, if you're as old as I am, you remember that influenza B was a cause of this when children took aspirin back in the bad old days. If you see bacterial pneumonia complicating the flu, it's really important to do a good workup and to get your cultures done. I think the nasal MRSA screen can be invaluable in helping to direct your antibiotic choices. You're going to want to use a broad spectrum agent, and if you think it's MRSA because you've got dense consolidation or a pleural effusion, or you've done a nasal MRSA screen that's positive, you're going to want to include an agent with MRSA coverage, usually vancomycin. So diagnosis. In the real world in which I think most of you live, This is a clinical diagnosis for most of us, especially during the season. So if it's January and February, you know there's flu out there circulating, and the patient presents with classic flu symptoms and findings that I've just described to you. You don't have to do any special workup. You can make that diagnosis clinically, and if they need treatment, you can provide that empirically. Now, of course, there are ways that we can confirm the diagnosis. Historically, we've used virus culture, but of course, that's slow and not practical for management of patients. There are rapid antigen detection tests, which I think are still useful, but you have to know the limitations. The sensitivity is variable. It's 40 to 80% is what's reported. It does tend to be a little higher in children. The specificity means, how often do you see false positives is better, but that depends on pretest probability. So if you're doing a flu test by one of these rapid antigen detection tests in June and you get a positive result, it's more likely to be a false positive than a true positive. That's pretest probability. The best, most reliable way to diagnose or confirm the diagnosis of flu is with the PCR tests that are used by most hospitals nowadays. And of course, you can get them in the ambulatory setting as well. They're really, really sensitive and highly specific. So a couple more words on the rapid antigen tests. You have to know what you're using. Some of them detect A, some of them detect B. Some of them detect both and don't distinguish A or B. Some of them require nasopharyngeal specimens, some throat swab, others nasal wash, others nasal aspirate. So know what they test for, know what the specimen requirement is. The results are usually available very quickly, and that can really help you counsel the patient and help you to appropriately prescribe an antiviral if indicated. So again, useful, but know the limitations. So I told you this is going to be an interesting year. And so laboratories have developed multiplex tests to let you know, is it flu or is it SARS-CoV-2? Some tests have included RSV. So you may get a positive test and it will distinguish RSV, flu A, flu B, SARS-CoV-2. So you have to know what's out there, what's available in your community. Some of these are going to be available through public health laboratories. Unfortunately, the Holy Grail hasn't been achieved. We don't have a 15-minute test that is a multiplex test that tests for all of these viruses. So you're going to have to use your clinical sense as well as whatever test you have available to you. I put our inpatient test at Christiana Care, my health system, just showing you what we've gone to starting back in September that has a whole lot of viral targets and bacterial targets in addition to SARS-CoV-2. So know what's out there, know what's available to you. Who needs to be tested? Well, this really hasn't changed since 2009 when the CDC guidance came out with our last pandemic. So anybody who's hospitalized needs to be tested, and anybody else for whom a diagnosis will affect their medical care should be tested. So imagine pregnancy, immunosuppression, maybe you need it for infection control reasons, management of close contacts. Treatment. I want to talk some about treatment because there's some new developments. Most patients will only need supportive care. So that means fluids, antipyretics, over-the-counter medications. Just make them feel better. Support them till they get through their, 3 to 5 days of acute symptoms and get on the mend. And I obviously tell them to observe for any worsening symptoms or complications. But there are antiviral agents, as you know, and there are 3 classes. The ones that were available for decades, the adamantanes, inhibited the M2 ions. Remember that from the cartoon? So that the virus couldn't penetrate and uncoat and invade cells. So those included amantadine and rimantadine, which were good agents back in the day, but they only worked for influenza A, and they did have some significant side effects. Your workhorse drugs are going to be your neuraminidase inhibitors, which bind to the neuraminidase to prevent attachment to the cells. So you have one that's delivered by inhalation, that's zanamivir, one that's available orally, that's oseltamivir, and one that's IV, which is peramivir. And the new kid on the block is baloxavir. This is a cap-dependent endonuclease inhibitor. The cap is one end of, it's the 5' end of RNA, so it works in a unique fashion. So this has just been around for a couple of years. It was at first FDA approved back in October of 2018, and then for high-risk people in October of 19, and then just last week was approved for prophylaxis as a single dose. So the unique thing about it is it has a long half-life, and for both prophylaxis and treatment can be delivered as a single dose. Clinical efficacy is similar to oseltamivir, but actually the reduction in viral load is faster than oseltamivir, and in high-risk adults with influenza B, they noted a faster recovery time. Unfortunately, it's 3 times more expensive, and we're beginning to learn that it's pretty easy to develop resistance to baloxavir. So here is a chart with antiviral susceptibilities, and I show it for a couple of reasons. So right now, all of the circulating strains are susceptible to our neuraminidase inhibitors, oseltamivir and zanamivir. They are resistant to the adamantanes like rimantadine. In the bottom row, grayed out, is what we saw with the old H1N1 that circulated up until 2009. And I show that because it was resistant to oseltamivir, but susceptible to rimantadine. So we can't forget about the adamantanes. They may become useful at some point in the future if we see widespread resistance to some of these other drugs. And we have to be, all of us, very careful about not inducing resistance to our antivirals by overprescribing. The efficacy of the neuraminidase inhibitors and what led to their approval by the FDA was established in previously healthy volunteers. It was often college kids who allowed themselves to be experimentally infected by influenza virus. Then they got placebo or they got the drug. And what was shown is that you could reduce the duration of illness by 1 to 2 days, and you could reduce the height of the fever by 1 to 2 degrees. So, made people feel better, right? But really, it was in 2009 where we learned how important these drugs were to patient outcomes in terms of preventing things like pneumonia, respiratory failure, exacerbation of chronic disease. There was a mortality benefit, decreased length of stay of hospitalization. So these are really, really important drugs. Like I said, your workhorses. So this chart came out in 2009 from CDC. It just says what should you do as far as antiviral therapy in somebody who comes in with mild or uncomplicated flu? Well, if they have no risk factors, which I'll show you on an upcoming slide, you may not need to use an antiviral. Just provide them instructions for symptomatic care, tell them to watch for any kind of worsening or complications and get back with you. If, on the other hand, they do have risk factors, there are many risk factors that I'll go over, these are candidates for antiviral therapy. And of course, if it's someone who has severe illness, when they first present to you, they need to be treated with an antiviral agent. So who are people who have high risk for complications? Well, it's young children, as I've already told you, younger than 2, adults over 65, pregnant women, people, young people on aspirin because of the theoretical risk of Reye's syndrome, and then anybody who has other chronic medical conditions, which is almost everything, as I'll show you. These are all candidates for treatment. So it's lung disease, heart disease, malignancy, kidney disease, liver disease, diabetes, hemoglobinopathies, immune suppression, certain rheumatologic conditions, especially if they're receiving biologic or high doses of immunosuppressive drugs, if they're compromised in terms of being able to handle their respiratory secretions, like children with neuromuscular conditions, children with metabolic disorders, their lungs and heart may be fine, but you can throw them into a severe hypoglycemic episode if they've got a mitochondrial disorder. Severe obesity, indigenous populations, we know that they're at high risk as well. So these drugs can be used for prophylaxis in addition to treatment, but the CDC hastens to point out that they aren't a substitute for influenza vaccination. So I've already shown you that oseltamivir resistance in the old H1N1 became a problem, and that's partly because people were not careful and they were using widespread prophylaxis. So vaccination is your mainstay, your main defense, your vanguard against influenza. But you should consider people a candidate for prophylaxis if they have close contact with infection and have been unvaccinated or just very recently vaccinated, because we know it takes about 2 weeks to mount an immune response. If they're immunodeficient and may not mount an immune response, if the person is high risk and was close contacts when the vaccine strains don't match the circulating strains, which can happen, and if they're in a long-term care facility, you may need to do it to control an outbreak. So I think we should be fairly selective in using prophylaxis and, again, emphasizing immunization as our main line of defense. The next 2 slides give you the doses. So for oseltamivir, treatment dose is twice daily. Prophylaxis is once daily. So you see it's 75 milligrams for adults, and then it's weight-based for children. And then a few years back, the FDA gave first emergency use authorization and then final approval for infant dosing, which is 3 milligrams per kilogram twice daily. Zanamivir, it's once daily for prophylaxis, twice daily for treatment. Of course, this is given by inhalation. And then baloxavir, the new one, is dosed based on the weight. So if it's an individual between 40 and 80, you give them 40 milligrams. If they're greater than 80 kilograms, you give them 80 milligrams. So that's kind of easy to remember. And then just, as I said, last Monday, the FDA gave approval for prophylaxis, again, weight-based, as you see. So in terms of antiviral therapy, any antiviral, they work better when you give them early. So initiate them as quickly as possible. But if it's somebody who's at high risk, later treatment is acceptable. It's recommended by CDC. So early is better, later if you have to. And don't wait for laboratory confirmation. If it's somebody at high risk, they need it as quickly as possible. The FDA has approved the neuraminidase inhibitors for 5-day treatment, but you can go longer if you've got somebody with a severe illness. And if you're in a situation of needing to provide prophylaxis, initiate it as quickly as possible after the exposure. Here are some of the side effects associated with these drugs. The older ones, they produced CNS side effects. I used to use these drugs, and people would tell you that they would have weird dreams or they get very anxious. Oseltamivir, just be aware that about 10% of people will get a little nausea. Zanamivir, by inhalation, no surprise, can induce bronchospasm, so use with caution. People who have pre-existing lung conditions. Baloxavir seems to be pretty safe, diarrhea in about 3%. So the rest of the time, we're going to devote to immunization. So here's some questions for you to ponder. Which of the following do you do? Give flu vaccine to patients who present in the fall or winter for other reasons? How about call or send reminders to high-risk patients to get their flu shot? Immunize household contacts of infants under 6 months of age? Or give flu vaccine after the first of the year? So actually, all of the choices are correct and recommended. You should do all of those. The idea here is to maximize our influenza vaccine coverage in your patients and in the total population. So again, I've been around for a while, and kind of a junior fluologist. So I've been watching the flu vaccination strategies evolve over the last few decades. So back in the 80s, we recommended flu vaccine for anybody over 65 or who was at least 6 months of age who had medical problems. And then in the 90s, early 90s, I think it was, we went to over 50 years of age or 6 months old and medical problems. And then public health authorities finally began to pay attention to the fact that children are really central to the epidemiology, and they could get sick and they could get hospitalized. So the recommendation went to all of the above plus 6 months to 5 years. And then even better, we went to all kids 6 months to 18 years. And that was up until 2009. Beginning in 2011, after we had that bad season in 29, the public health authorities at CDC and everywhere recommended routine vaccination, universal vaccination of everybody above 6 months of age. I'll show you in a little while how well that's working out. Now, this universal recommendation doesn't detract from the importance of the populations I just showed you, but if you use over 50 and over 6 months with medical problems and everybody up to 18 years, that was already 85% of the population. And by doing the universal recommendation, it eliminated the need to determine if vaccine was indicated. So you didn't have to go through all the charts in your office or in your electronic record and pick out which ones to give and which ones to not bother. The universal recommendation also recognizes that morbidity and even mortality can occur in previously low-risk people. We know that you get better herd protection or community immunity the more people you vaccinate. And in fact, these vaccines are generally safe and effective. So why not do it? Why not do it as broadly as possible? So you figured it out by now. I'm kind of a history buff, so I'm going to give you a little history on influenza vaccines. The trivalent inactivated vaccine has been around for decades. It used to be called TIV. Now we call it IIV. The live attenuated influenza vaccine was approved in 2003 and was an important part of our armamentarium for a number of years. Still is. High-dose influenza vaccine for seniors was approved in 2011. 2013 was a big year because we got the first quadrivalent vaccines and 2 new technologies for vaccines, which I'll go over. And all of these contain multiple flu strains each year, usually 2A, an H3N2, and an H1N1, and a B strain. Unfortunately, as you know, in most years, the vaccine strains drift or sometimes shift. So combining that with the fact that duration of immunity from vaccines is only about a year, we have to give flu vaccines every single year. This shows 14 influenza seasons and how efficacious the flu vaccine is. And this is across the population. This is old people, young people, white people, people of color, blah, blah, blah. And so you can see that most years it's 40 to 60%, sometimes a little bit lower. It typically is higher for children than for adults. It's typically higher for preventing severe illness than for preventing mild illness. And it typically is lower for H3N2, which is bad because H3N2, years that have H3N2 activity are usually our bad years. It is what it is. But don't let people tell you, I'm not getting it because last year it was only 40% effective or 37% effective. Because if you don't get it, it's exactly 0% effective. So I've gone from emphasizing efficacy to impact, and that's what a lot of public health authorities say. Now, don't talk 40% efficacy with patients. Say, here's the impact. That this, as a result of flu immunization, we had 4.4 million fewer cases of flu last year. We had 58,000 fewer hospitalizations, and we had 3,500 fewer flu deaths. That's how we should present this to patients. So again, nomenclature has changed. We call it IIV now, not TIV, and that can be IIV3 for trivalent inactivated vaccine, or IIV4 for quadrivalent inactivated vaccine. RIV stands for recombinant influenza vaccine, and LAIV, as you know, is the live attenuated influenza vaccine. Here's what you're using this year. Hopefully, all of you have already immunized many people, if not most of the patients you hope to get immunized. So there's only one trivalent vaccine at this point in time, as I'll show you momentarily, and it contains the three strains that you see, H1N1, H3N2, and the Victoria strain. All of the others for this season are quadrivalent, so they contain all of the above, plus the Yamagata B strain. So all of the vaccines that are available are on the next two slides. So here are your workhorse vaccines, the quadrivalent inactivated vaccines that most of you have given most of your patients. I've just highlighted a couple of things. So pay attention to the age indications. Pay attention to whether they contain mercury, because in some jurisdictions, like the state where I practice, using mercury-containing vaccines is prohibited for children and pregnant women. Not that it should be. Pay attention also to the fact that some of the presentations have changed, and I highlighted in gold there the change in Fluarix and Fluvaval that I'll come back to. These are your workhorses, the quadrivalent inactivated vaccines. But then there are these other unique and often useful vaccines as well. So Flublok is recombinant, indicated for age 18 and up. Recombinant meaning made in a test tube and not involving any eggs whatsoever. Fluzone high dose just came out this year. So the flu dose that you've known before was a trivalent. This is quadrivalent, and it has gone from a 0.5 ml dose to a 0.7 ml dose, obviously indicated for people at least 65 years of age. The flu mist has been a quadrivalent preparation for several years now, obviously delivered by the intranasal sprayer and indicated for otherwise healthy non-pregnant people not between 2 and 49 years of age. Flucelvax is made in cell culture, so has just the tiniest traces of egg, truly not to be worried about, indicated at age 4 years and up. And then Fluad is one of our newer preparations that's adjuvanted, indicated for older people who might not mount a good immune response. And that's the only trivalent that's still available. I don't know why you'd want to use it, because there is a quadrivalent version of that same product. So you've all seen Dr. Anthony Fauci on television every day, if not more frequently, in the last 8 or 9 months. But he's the guy who's been a big proponent of this as well. And Dr. Fauci, who I trust 100%, says that we can expect a universal flu vaccine within the next few years. And the idea here is that I told you that due to drifting and shifting, and mostly drifting, flu strains change from year to year. And that is because we use the antigens from the head of the hemagglutinin molecule, the top of it, shown on the picture. The universal flu vaccines involve the antigens from the stem or stalk of the vaccine, which is more highly conserved and doesn't change as much from year to year. The goal when we have a universal flu vaccine will be that it will be at least 75% effective. It'll protect against most influenza A viruses, will be durable, maybe more than the year that we now quote, and will be suitable for all age groups. And the reason this is so important is because a lethal outbreak is just a mutation away. Remember your H5N1 or your H7 viruses. You know, if they mutate in a way that makes them more transmissible person to person, we're in big trouble. Speaking of that, we now have an H5N1 flu vaccine that's FDA approved for use in this country. In case we do have H5 activity, heaven forbid. It is indicated for 6 months and greater for prevention of disease due to H5N1. A few words about issues particular to pediatric patients, because I'm a pediatrician. So, first of all, the best way to protect infants under 6 months of age is to either immunize mom during pregnancy using IIV, not LAIV, and to immunize household contacts, so-called cocoon strategy, right? So everybody around them is protected. And when you immunize mom during pregnancy, she passes on some of her IgG antibody to the influenza viruses to the baby. So that's a great way to protect the young infant. If it's a child 6 months to 35 months, you'll be using quadrivalent vaccines. And just to be clear, the formulations have changed in the last couple of years. Afluria is still a 0.25 ml dose, which is what we've used for decades in this age group. But Fluarix and Flulaval have changed to a 0.5 ml dose, which uses 15 micrograms instead of 7.5 micrograms. And that's because research has shown that it's safe and well tolerated. But remember that dose change. And then to confuse us even further, Fluzone, which is one of the probably the most widely used brands, they have got a 7.5 microgram containing dose and a 15 microgram containing dose, and you can use either for 6 months to 35 months. So just be aware of this and know what you're given, know what's in your fridge, and make sure to do it right. Now, if it's a child at least 9 years of age, then it's fairly simple. They get one dose a year of the flu vaccine, whatever product you choose to use that's indicated. If it's a child under 9 who's never been vaccinated, then you have to give 2 doses to get an adequate immune response. And you can use either IIV4 or LAIV. And then, of course, if it's a child under 9 who's been previously vaccinated, you really have to dig a little and figure out, do they need 1 dose or do they need 2 doses this year? So you have to, most years, this chart changes. It comes out in August or September. It's put out by the CDC, it's put out by the American Academy of Pediatrics. So you ask the question, did the child receive at least 2 doses of a trivalent or quadrivalent influenza vaccine before July 1st? And it could be different flu years. If the answer is yes, they only need 1 dose. If it's no or they don't know, you have to do 2 doses. A couple of words about LAIV. I was always a big fan of this. LAIV is, excuse me, cold adapted, which means it's grown in the laboratory. They train the virus to grow better at 34 degrees than 37 degrees. So it replicates in the nose, but doesn't get down in the lungs. It is live, it's attenuated, so it's not likely to cause true disease. So it's cold adapted and attenuated, making it safe. And it induces both mucosal immunity, often IgA, and serum immunity, IgG. So it really was, in many years, a better vaccine for pediatric patients. It wasn't quite as popular for adult patients for a variety of reasons. But we had a couple of years this past decade where LAIV didn't perform very well, and it was mostly due to coverage of H1N1. And so, as you probably remember, for a couple of years, it was not recommended. The manufacturer then changed to a new strain of H1N1, got a better immune response. So the last 2 years, it has been recommended by both CDC and American Academy of Pediatrics as an effective alternative for immunizing kids or anybody 2 years to 49 years. And then you get in the question of wheezing, and if they've had 2 episodes of wheezing, blah, blah, blah. We can go into that if there are questions, but certainly feel free to use LAIV. I think it's a good tool in your toolbox. So all of our vaccines are generally safe, but should not be given to certain groups. So people who've had a severe reaction to an influenza vaccine, that's the only contraindication. if they've had a severe reaction. The others are precautions. So people who have developed Guillain-Barré within 6 weeks of getting a flu vaccine, children less than 6 months, well, it's not a contraindication or a precaution. It's just not indicated. And people who have a moderate to severe illness with a fever, let them get over their illness and then zap them. This question often gets raised. Should pregnant women receive the flu vaccine? And the answer is categorical yes. We know that pregnant women are at risk for flu complications, including deaths. So it's a great way to protect the mother, but it's also an excellent way to protect the infant. There was this study, bad study, published in 2017 that suggested that miscarriage might occur as a result of flu vaccination. I don't think anybody believes that at this point in time. It was a bad study. ACOG has not changed their position. I think all scientists, all doctors should agree that pregnancy is indeed a condition for which we should vaccinate. Patients with egg allergy. Now, this has changed too over the years. So used to be we shied away from giving flu shots to people with egg allergy because we were worried they would get an anaphylactic reaction and die. Turns out that hardly ever happened. So the last few years, ACIP, the Advisory Committee on Immunization Practices, CDC, has recommended that if the patient only has hives from egg exposure, you can give any age-appropriate vaccine. Of course, you can use the recombinant vaccine that doesn't have any egg proteins, but you can use any age-appropriate vaccine. On the other hand, if they've had a more severe reaction like angioedema, respiratory distress, etc., you can use any appropriate vaccine, but it has to be done in an inpatient or outpatient setting where emergency equipment is available and resuscitation can be provided if people have a severe reaction. Okay? Here's how we're doing. Now remember, 2010-2011 on the left-hand side of the chart was the first year in which universal vaccination was recommended. So we've crept up a little over the last decade. The thick black line is for all pediatric patients, so we're around 63%. A bit better for kids under 4 and a bit worse for teenagers, older kids, I should say. So, is that good enough? Really? Is that good enough? No, it's not. Here's adults. So, again, since the universal recommendation's been out, not a great increase. And it's just, I don't know, I just have a real problem when I look at a chart like this. So for all adults, 45%. For older adults who are at high risk of hospitalization and death, 68%. Younger adults, even worse. So point is, loud and clear, we all need to do better. And I'm not saying we as healthcare providers. I think most of us try to immunize our patients, but we need to get the population to accept, endorse, and even embrace flu vaccination. You can noodle around on the CDC website and find this. And by the way, word of the wise, if you're looking for something on the CDC website, Google it. Don't go to cdc.gov because it's hard to navigate. But whatever you want to find, just put it into Google or whatever your favorite search engine is, and then it'll take you to the part of CDC that you're looking for much quicker. So I Googled flu vaccination rates, Delaware, and you can see what your flu vaccination is based on the age of the patient, where you live, where you practice. So I happen to highlight 6 months to 4 years because we're doing a really good job in this little state of Delaware, well ahead of the Healthy People 2020 goal. Well, a little bit room for improvement in the other populations, but something you probably ought to take a look at. Here was a poll of why people don't get flu vaccines. So top choices are, I don't need it, I get side effects. It gives you the flu. That's a major myth. There's nothing about the flu vaccine. It can't give you the flu. Inconvenient, blah, blah, blah. I'm allergic. I don't think so. Not for most people. So our job is to be myth busters and to deal with this. And you can find these kind of posters and brochures on CDC website. You can find them other places as well. And tell your patients this year that this year may be more important than ever to get immunized. Again, I can't predict what kind of flu year we're going to have. If it's like the Southern Hemisphere, I'll be happy, but I don't know. We're just learning what it's like for people to get simultaneous COVID and flu. And I don't think there are great data out there. I think it could be really bad if people got both at the same time. Not only that, but if we get a lot of flu, we're going to overburden our health systems. And you turn on the television, folks, it's already happening. Here at my hospital, I go to our website every morning and look at our COVID data, and we've got 158 patients in the hospital right now, 158 patients with COVID, which is more than we had in April and May. So it's going to be bad, and immunizing against the flu for these reasons is just extremely important. We should all get it, right? Healthcare workers, we're important. We need to protect ourselves because we have critical jobs to do now more than ever. We can't afford to get ill. We can't afford absenteeism. We can't afford presenteeism. That presenteeism is a term that means, well, you're at work, you're seeing patients, but you're really moving slow and you're not doing a good job. The recommendation for healthcare workers to receive it also is because we want to protect our patients. We don't want to turn around and give a virus to our patients that could harm them or set off an outbreak. And we know that these vaccines are generally safe and effective, and routine vaccination of healthcare workers is endorsed by all of our professional organizations. So this was me a few years back, and I will never forget this. Because that's our employee health nurse. She knew that this was the kickoff to our flu campaign, our flu blitz. And she knew that we were being photographed. It was going to be posted on the website and all this. So she was nervous, and she poked the needle in and then jerked it right back out and had to poke me a second time. And I thought that was worth sharing with all of you. My point is, though, all of us should be leaders and set examples. So all of us should get immunized for these reasons as well. Wow, I went on and on about the flu, but I'm happy to take any questions, and that would be questions on flu or questions on antibiotics. And again, I'm going to rely on Rick because I cannot see the chat on my screen.
If you hover near the bottom with your mouse, it should pop up and say chat. I don't see anything in the chat, but I will open up the microphones in case anyone would like to ask a question. And I'm getting to that now.
Yes, are you able to hear me?
Yep.
Okay.
Loud and clear, Katie.
Okay, thank you. I just have a question regarding strep. So if you have a patient that you've treated like with amoxicillin for group A strep, and then they finish the 10 days or close to the 10 days, they come back, they're still symptomatic. Of course, you do a throat culture maybe, but retest them with a rapid test and it's still showing group A. Would you do something like Augmentin, or would you go to like clindamycin?
So that's a good question, and I hear pediatricians bring that up not infrequently, and it's hard to tell. So that could be a treatment failure, and there are treatment failures, or it could be a child who's colonized with group A strep and maybe had a viral illness and just tested positive. So either of those could result in somebody being, rapid test positive or culture positive at the end of a treatment course. So if it's a true treatment failure, one reason is the innocent bystander theory. You've probably heard this. So perhaps the child has Staph aureus in the throat or another beta-lactamase producing organism. So you're giving amoxicillin or penicillin, and the other organism in the throat is breaking it down, so it's not as effective against the strep. So that's, you mentioned the clindamycin option. So that's one reason for doing that. Or Augmentin. People sometimes use amoxiclav for the same reason, to eliminate that innocent bystander. If you are thinking that this is a carrier, one way you can do it, and this involves blood work and a little bit of expense, is to check an ASO titer. If you check the ASO, and it's less than 200, that's probably a carrier state, and you may not have to retreat that child. So there's a couple of ways you could approach that. Here's another thing. You didn't ask this, but I'll share it with you anyway. If you think you've got a carrier and the kid's just positive over and over again, and you or your partner or somebody else keeps treating them over and over again, one way to clear the carrier state is to use rifampin. And the way you do that is during your last 4 days of amoxicillin, days 7 through 10, you give concomitant rifampin, and it knocks off the carrier state because it gets very high mucosal levels.
Okay, thank you.
Great. Polly, did you have a question?
No, I was just, I was listening to what Katie and I had talked about that question, because we had that a lot in the college population, where they would come back and have positive results after being treated.
Okay.
Well, hopefully one of those pearls will help you.
Yes,
Yeah.
thank you.
That's good. Yeah.
Great. Well, I'd like to thank you all for joining us tonight, and thank you to Dr. Eppes. Great job. Really appreciate it. And we'll be back again next Tuesday at 6:30 p.m.